There is something sitting in the medicine cabinet of most people over 60 in America right now. Something they reach for without thinking. Something their pharmacist didn't warn them about. Something their eye doctor may not have explained clearly. And something that the research now shows is actively making the very problem they bought it to solve significantly worse. Not slightly worse. Measurably, biologically, structurally worse. And what makes this particularly hard to detect is that it doesn't happen the first time you use it, or the second week, or even the first month. The damage accumulates slowly, quietly, in a way that is almost impossible to notice until the window to reverse it has begun to close. I want to spend the next several minutes walking you through exactly what is happening at the surface of your eye when you use certain types of eye drops, how those changes connect to conditions like dry eye disease, macular degeneration, and glaucoma, and which 5 specific categories of drops I would personally never recommend to a patient over 60 who is using them on a regular basis. And I want to start with the biology because once you understand what is actually happening inside the eye, the concern becomes impossible to dismiss. I have spent years working in clinical eye care and age-related vision research, and the pattern I keep encountering is this. Patients come in with worsening dryness, increasing redness, blurring that comes and goes, and a growing dependence on drops they bought at the drugstore. They are using more drops than they were 6 months ago, and yet feeling less relief. And when we look at what they are using and how long they have been using it, the connection becomes clear. The drops are not failing to work. In some cases, the drops are the reason the symptoms are escalating. Here is what you need to understand first. Your eye is not a passive surface. The outer layer of your eye, the tear film, is a 3-part structure that is rebuilt and maintained by living cells every single time you blink. The outermost layer is a lipid layer produced by glands in your eyelids that prevents evaporation. Beneath it is the aqueous layer, the watery component that carries oxygen and nutrients to the cornea. And beneath that is a mucin layer produced by cells called goblet cells embedded in the conjunctiva that anchors the entire tear film to the surface of the eye. These 3 layers work together in a coordinated biological system. When that system is healthy, it protects the cornea, maintains clear vision, and renews itself with each blink. When it is disrupted, dryness, inflammation, and surface damage follow. After the age of 60, this system is already under pressure. Tear volume decreases, the lipid layer thins, goblet cell density in the conjunctiva begins to decline. The corneal epithelium, the clear outer surface of the eye, regenerates more slowly because the stem cells responsible for that regeneration, the limbal stem cells that live at the junction of the cornea and the white of the eye, have reduced activity compared to younger years. Your eye, in other words, is already working harder to maintain itself. The margin for additional insult is smaller than it was at 40, and this matters enormously for what I am about to tell you about the drops. The first category is what I consider the most common source of harm in people over 60, and it is in nearly every medicine cabinet in America. These are the redness relief drops. Vicine Original, Clear Eyes, the generic versions that say redness relief on the label. The active ingredient in most of these products is tetrahydrozoline. In some formulations, it is nafazoline. Both are in a class of drugs called alpha-adrenergic agonists or vasoconstrictors. What they do is cause the tiny blood vessels on the surface of the eye, the conjunctival blood vessels, to constrict, to physically tighten. And when those vessels constrict, the redness disappears. Rapidly, visibly, it works in minutes, and it looks remarkable. Here is what is actually happening. Those blood vessels are red because they are dilated. They dilate in response to a signal. That signal is usually irritation, dryness, allergen exposure, or inflammation. In other words, the redness is a biological response. It is your eye increasing blood flow to a tissue that is experiencing stress. When you apply a vasoconstrictor, you are not treating the signal. You are suppressing the visible result of the signal. The underlying cause remains completely untouched. Now here is where it becomes a compounding problem after 60. With repeated use of these vasoconstrictors, the blood vessels become accustomed to the chemical constriction. When the drop wears off, they rebound. They dilate wider than they did before you applied the drop. This is called rebound hyperemia or conjunctivitis medicamentosa. Published case data shows that tachyphylaxis, meaning reduced effectiveness with repeated use, can develop with tetrahydrozoline in as few as 5 to 10 days of daily use. And once that rebound cycle is established, stopping the drops produces a period of worse redness than you started with, which drives most people to continue using the drops to manage the symptoms the drops themselves are creating. But there is a second concern for older eyes specifically. After 60, the cornea depends heavily on blood flow to the conjunctival vessels for metabolic support because the cornea itself has no blood vessels. When you chronically suppress those vessels, you are restricting oxygen and nutrient delivery to tissue that is already regenerating more slowly than it did at younger ages. With prolonged use, the conjunctival blood vessels can become permanently enlarged. You are not just masking a symptom, you are chronically altering the vascular architecture of your eye. The American Academy of Ophthalmology explicitly states that redness-relief drops can make redness worse when the drops wear off, and that this rebound effect can worsen over time. And there is something more important underneath all of this, which I will come back to later in this video. Persistent redness is a signal worth reading. It is often the first visible indication of dry eye disease, blepharitis, early glaucoma, or other conditions that genuinely require evaluation. Suppressing the redness means the signal disappears from view while the underlying condition advances. And I want to be specific about what chronic use means in this context because it is important. If you have used a redness relief drop once or twice over the past year during an unavoidable situation, that is not the pattern I am describing. The concern is daily use or near daily use, sustained over weeks, months, or longer. This is a pattern that is far more common than people realize, particularly in older adults who have become dependent on the drop to manage a persistent redness they do not realize is partly caused by the drop itself. If you recognize this pattern in yourself, the withdrawal period when you stop these drops, during which the eyes may look temporarily redder than they did before you started, typically resolves within days to a few weeks, depending on how long the habit has been established. Preservative-free lubricating drops can support the surface during that transition. But the rebound is real, it is temporary, and it is worth understanding before you interpret worsening redness as evidence that you need more drops. There is one more mechanism I want to describe within this first category, because it connects to a risk that goes beyond cosmetic redness. These vasoconstrictors work by stimulating alpha-adrenergic receptors in the conjunctival blood vessels. In older eyes, particularly those with early or undiagnosed angle closure glaucoma risk, stimulation of certain adrenergic receptors can influence the drainage angle of the eye. Some formulations and their close relatives have been associated with pupil dilation, and pupil dilation in a patient with a narrow anterior chamber angle can precipitate an acute episode of angle closure glaucoma, a rapid and painful rise in eye pressure that constitutes a medical emergency. Visine itself carries a warning that the product should not be used by patients with narrow angle glaucoma, but narrow angle anatomy is frequently unknown to the patient until it is discovered by an eye doctor during examination. A large proportion of people over 60 who have never had a comprehensive eye exam in adulthood have never had their drainage angle assessed, and these are exactly the people who are most likely to be self-treating redness with drugstore drops without any professional evaluation of whether it is safe to do so. The second category is one that surprises people because the product involved is generally marketed as gentle, soothing, and appropriate for regular use. I am talking about preserved artificial tears. The most commonly used preservative in multi-dose eye drop bottles is a compound called benzalkonium chloride, abbreviated BAC. BAC has been used in ophthalmic formulations since the 1940s. It is present in approximately 70% of all eye drop products on the market, and it has been in ophthalmic use for so long that many people assume its safety for long-term use has been thoroughly established. The research says something quite different. BAC is a quaternary ammonium compound. It works as a preservative by essentially functioning as a detergent. It kills microorganisms by rupturing their outer membranes. The problem is that it does not confine this mechanism to microorganisms. Published in Investigative Ophthalmology and Visual Science, a study from researchers at UC Davis and the Institut de la Vision in Paris demonstrated that BAC, at concentrations present in standard eye drop formulations, inhibits mitochondrial function in human corneal epithelial cells. To be precise, it inhibited mitochondrial ATP synthesis, the cell's energy production, with an IC50 of 5.3 micromolar. The concentrations in standard eye drops are between 107 and 667 micromolar, meaning the drug is being applied at concentrations that are in some cases more than 50 times higher than what begins to compromise cellular energy in the cornea's surface cells. What this means in practical terms is this. Each time a preserved drop is applied, BAK disrupts the lipid layer of the tear film. The tear film's outermost protective layer cannot fully regenerate between applications. The aqueous layer is exposed. The cornea becomes more vulnerable to evaporation and environmental irritants. Over time, BAK causes a measurable loss of goblet cells, the mucin-secreting cells that anchor the tear film. A study examining goblet cell viability found that when exposed to BAK-preserved drops, goblet cell survival was only 46% compared to 81% in the preservative-free condition. And the consequences go deeper than the surface. A 2025 study published in the journal Scientific Reports examined the toxic effect of benzalkonium chloride on human limbal stem cells, the corneal stem cells responsible for regenerating the surface of the eye. These stem cells, which are already less active after 60, were shown to be directly harmed by BAK exposure. The researchers found that BAK exposure triggered apoptosis, meaning programmed cell death, in the limbal stem cells and altered the expression of genes related to proliferation and wound healing. When your limbal stem cells are damaged, the cornea's capacity to repair itself is compromised at the most fundamental level. Think about what this means mechanically. The cornea is one of the fastest renewing tissues in the human body. It turns over its entire epithelial surface roughly every 7 to 10 days, driven by limbal stem cells that divide, migrate inward, and differentiate into the cells that form that clear outer window. This process is continuous, it never stops, and it depends entirely on those stem cells being viable and functional. When they are being chemically injured every time you apply a drop, the renewal process slows. Microdamage accumulates. The surface of the eye becomes subtly less uniform. Light scattering increases. Vision quality, not just acuity, but the crispness and contrast of what you see, begins to degrade in a way that does not always show up on a standard eye chart test, but is very much present in daily life. And this is specifically more consequential after 60 because the baseline reserve of limbal stem cell activity is already lower. You have less capacity to absorb repeated insult and fully recover. Here's the paradox that the published literature now explicitly identifies. Preserved artificial tears, particularly those containing BAK, can paradoxically aggravate the very dry eye disease they are intended to relieve. A large-scale study published in the journal Acta Ophthalmologica in 2025, analyzing data from nearly 68,000 participants, found that users of BAK-preserved artificial tears had significantly higher odds of reporting itching and blurred vision compared to users of preservative-free formulations. The dry eye is getting worse, and the product being used to treat it is contributing to that worsening. This is not a niche concern or a theoretical risk. It is a documented, dose-dependent, time-dependent biological process, and it is specifically more problematic after 60, when the ocular surface has less regenerative reserve and the stem cells responsible for corneal renewal are already under pressure. The third category is one that many older patients are using under direct medical supervision, and appropriately so for their underlying condition. I am not suggesting these should be discontinued without physician guidance. But I am saying that if you are over 60 and using these drops, you need to understand exactly what the research shows about how they affect the eye beyond their intended target. I am referring to beta-blocker glaucoma drops. The most common is timolol maleate, present in brand names like Timoptic. Timolol has been prescribed for glaucoma since its FDA approval in 1978. It lowers intraocular pressure effectively by reducing the production of aqueous humor inside the eye. For many years, it was the first-line treatment for open-angle glaucoma. Today, most treatment guidelines prefer prostaglandin analogs as the first-line agent, with timolol typically reserved for cases where prostaglandins are insufficient or contraindicated. And there is a reason for that shift. When you apply timolol eye drops, approximately 80% of each drop drains through the nasolacrimal duct, the channel connecting the eye to the nasal passage, and is absorbed directly into the systemic circulation through the nasal mucosa. It bypasses first-pass metabolism in the liver. This means the systemic bioavailability of ophthalmic timolol is approximately 78%, compared to about 61% for oral timolol taken by mouth. In pharmacological terms, putting timolol in your eye delivers nearly as much drug to your bloodstream as swallowing a pill, but without the liver processing that would otherwise reduce the dose. Timolol is a non-selective beta blocker. It blocks both beta-1 receptors, which regulate heart rate and cardiac output, and beta-2 receptors, which regulate airway dilation. A study published in the Annals of Internal Medicine demonstrated that ophthalmic timolol significantly decreased resting heart rate and maximal exercise heart rate after just the first dose. Over chronic use, it reduced oxygen consumption at maximal exercise and impaired exercise capacity in healthy volunteers. In elderly patients, published evidence confirms that the beta-blocking effect is both stronger and lasts longer than in younger patients. There have been documented cases of timolol eye drops causing bradycardia severe enough to require hospitalization. Cases of syncope and falls in elderly patients have been traced to orthostatic hypotension caused by timolol drops. A case reported in BMC Pharmacology and Toxicology documented complete atrioventricular heart block in a 62-year-old patient on timolol eye drops with a heart rate of 29 beats per minute requiring intensive care. The block resolved 48 hours after the timolol was discontinued. A population-level observational study found a significantly increased risk of hospitalization for bradycardia in the 31 to 180 days following initiation of timolol eye drops, with the mean age of affected patients being 82 years. For patients who also have chronic obstructive pulmonary disease or asthma, the beta-2 receptor blockade from timolol can trigger bronchospasm. This is documented and on the prescribing label. What makes this particularly insidious is the route of administration. Most patients understand intuitively that putting a drop in the eye is a local treatment. What they do not understand, and what is often not explained clearly, is that the eye is not a closed system. The nasolacrimal duct connects your eye to your nasal passage, and from there to a mucous membrane with rich systemic absorption. When you put a drop of timolol in your eye, the majority of it does not stay in the eye. It drains, and when it reaches the nasal mucosa, it enters your bloodstream directly, bypassing the liver's first-pass filtration that would otherwise moderate its effect. This is why researchers have measured the systemic bioavailability of ophthalmic timolol at approximately 78% of the administered dose. You apply a drop to your eye, and 3/4 of it behaves as if you had taken it intravenously. In an 80-year-old patient with reduced kidney clearance and slower drug metabolism, the half-life is extended, meaning the drug remains active in the system longer than it would in a younger person. There is a simple technique documented in the ophthalmology literature and recommended by multiple professional societies that can reduce systemic absorption significantly. It is called nasolacrimal occlusion. After applying the drop, you gently press your finger against the inner corner of the eye over the lacrimal punctum for 1 to 2 minutes. This physically blocks the drainage channel and allows the drop to absorb into the eye rather than drain into the nasal passage. Studies show this can reduce systemic absorption by up to 60%. This is a piece of information that is rarely communicated at the time of prescription, and yet it is directly relevant to the cardiac side effects I have just described. If you are on timolol eye drops and this was not explained to you, it is worth raising with your prescribing doctor immediately. None of this means timolol should not be used. Glaucoma causes irreversible optic nerve damage. Controlling intraocular pressure is essential, and for some patients, timolol remains the appropriate choice. What it means is that if you are over 60 and on timolol eye drops, and you have noticed unexplained fatigue, dizziness when standing, a sense that exercise feels harder than it used to, or any episodes of lightheadedness, the drops are a legitimate suspect worth discussing with both your ophthalmologist and your primary care physician simultaneously, and it means that the transition to a prostaglandin analog as the primary agent is worth asking about specifically, because the cardiovascular risk profile is meaningfully different. The fourth category involves steroid eye drops. These are prescribed, not available over the counter, and again, often prescribed for legitimate and important reasons. Post-surgical inflammation, uveitis, allergic reactions in the eye. The concern I want to flag for people over 60 is specifically the risk of what the medical literature calls steroid-induced ocular hypertension and steroid-induced glaucoma. Corticosteroid eye drops, including dexamethasone and prednisolone, which are among the most commonly prescribed, raise intraocular pressure in a meaningful subset of patients. The mechanism involves corticosteroid-induced changes in the trabecular meshwork, the drainage structure of the eye that regulates pressure. The steroids increase resistance to aqueous outflow and pressure rises. A long-term study published in a major ophthalmic journal followed patients using topical prednisolone acetate 1% over a median of 7 years. The cumulative risk of developing steroid-induced ocular hypertension was 29% at 1 year, 41% at 5 years, and 49% at 10 years. Nearly half of patients on long-term steroid drops developed elevated eye pressure. The reason this matters specifically for people over 60 is that age is an established risk factor for steroid response. Older adults are among the highest risk groups for steroid-induced pressure elevation, and the combination of pre-existing risk for glaucoma, which increases significantly with age, plus steroid-induced pressure elevation, creates a situation where the drug given to treat inflammation can accelerate the very optic nerve damage that glaucoma causes. The Mayo Clinic prescribing information for prednisolone eye drops states clearly that steroid eye drops can cause glaucoma and that they can promote the formation of posterior subcapsular cataracts with long-term use. A posterior subcapsular cataract forms at the back of the lens, directly in the path of light traveling to the retina. It is the type of cataract that disproportionately affects reading vision and causes significant glare with bright lights, symptoms that are often dismissed as normal aging before the connection to steroid use is made. And in a population that is already at elevated risk for cataracts simply by virtue of age, adding a medication-driven mechanism of lens clouding on top of that is a combination worth taking seriously. There is also a subtler long-term concern that relates to the way steroids interact with the immune surveillance of the ocular surface. The conjunctiva contains immune cells, particularly mast cells and T lymphocytes, that monitor the surface of the eye for pathogens and damaged tissue. Chronic corticosteroid use suppresses this surveillance function. In practice, this means that bacterial or viral infections of the eye, which would ordinarily produce clear symptoms and drive patients to seek treatment, can be masked or permitted to progress more quietly while the patient is on steroid drops. Herpetic keratitis, caused by the herpes simplex virus, is particularly dangerous in this context. Applying topical corticosteroids to an eye with an active herpes infection can cause the infection to spread rapidly and cause serious corneal damage. This is not a hypothetical risk. It is documented, serious, and one of the reasons corticosteroid eye drops carry the label warnings they do. If you are using steroid eye drops and have been on them for more than a few weeks, please ensure that your eye pressure is being monitored regularly. This is a straightforward measurement in any eye care office, and if you have been on them long-term, ask your ophthalmologist explicitly about your current intraocular pressure and whether a less potent formulation or a non-steroidal anti-inflammatory alternative might be appropriate. The fifth category is where the concern is different in nature and in some ways more broadly applicable to people over 60, because the mechanism here involves something that is happening inside your body well before you open a bottle of eye drops. This category is OTC antihistamine-containing eye drops used on a chronic basis for itching and allergy symptoms. The products include certain formulations of Visine A and similar combination drops that contain both an antihistamine and a vasoconstrictor. The concern is dual. First, many of these products still contain BAC as the preservative, which we have already discussed at length. Second, the vasoconstrictor component produces the same rebound redness cycle described for the first category. But beyond both of those issues, there is a structural concern about chronic antihistamine exposure to the ocular surface in the context of aging tear film biology. The tear film in people over 60 is already producing less mucin than younger eyes. Antihistamines have anticholinergic properties. They reduce secretion. Systemically taken, antihistamines are well documented to significantly reduce tear volume, which is precisely why oral antihistamines worsen dry eye symptoms. Topical ophthalmic antihistamines are designed to act locally and are considered safer than oral antihistamines in this regard, but the prescribing information for these products explicitly notes that they can cause headache, runny nose, and burning or stinging, and that if symptoms worsen rather than improve during use, the product should be discontinued. The critical word there is worsen. In an older eye with already compromised goblet cell density and a thin lipid layer, the BAC in these combination products can tip the balance. There is also something worth saying about the nature of the itch itself. Ocular itching in people over 60 is not always allergic in origin. A significant proportion of patients who present with chronic eye itching have dry eye disease as the primary driver. The nerve fibers in the cornea respond to desiccation by producing itch as well as pain signals. When patients reach for an antihistamine drop because their eye itches, but the itch is actually caused by a dry and desiccated corneal surface rather than a histamine response, the antihistamine component provides no relevant mechanism of relief, and the vasoconstrictor and back in the product add insult to the surface that was already the source of the problem. The patient uses the drop, feels temporary relief from the vasoconstriction, and interprets that as evidence that allergies were the cause. But what is actually happening is that the redness, which was a response to dryness and surface inflammation, is being masked, while the dryness that produced it continues or worsens. Getting the diagnosis right is not a minor detail here. It is the difference between a treatment that addresses the cause and one that obscures it. These drops do not address what is causing the eye to be red, itchy, irritated, or dry. They address the visible symptom. And there is a critical difference between those two things, particularly after 60. Persistent symptoms in aging eyes are frequently signals from an underlying process that is progressing. Chronic redness may reflect the early stages of ocular surface disease. Persistent itching in the absence of identifiable seasonal allergens may reflect dry eye presenting as itch rather than dryness, which is more common than most people realize. Worsening dryness despite regular use of artificial tears may reflect the tear film's lipid layer failing or goblet cell loss, both of which require specific interventions that artificial tears cannot provide. When you consistently suppress the signal with a drop that does not treat the cause, you lose the visible cue that would otherwise prompt you to seek evaluation. The condition advances, and by the time the symptom breaks through the suppression and becomes undeniable, the window for straightforward intervention may have narrowed. So what does the alternative look like? For dry eye, preservative-free artificial tears are not just a preferred option. For people over 60 using drops more than 4 times per day, or using them for any extended period, they are what the research supports. You will find them in single-dose vials or in multi-dose bottles with one-way valve dispensers that do not require preservatives. Products like Refresh Preservative-Free, TheraTears Preservative-Free, and Retain MGD are commonly available. They cost more per unit, but the cost of treating ocular surface disease that has been worsened by chronic back exposure is significantly higher in every sense of that word. For redness, the evaluation should be, why is the eye red? A single episode of redness from known causes, dust, smoke, a sleepless night, can reasonably be addressed with a brief course of a redness relief drop. But if redness is recurring, if you are reaching for the bottle more than a few times per week, that pattern warrants an eye examination, not a larger bottle of vasoconstrictor drops. For steroid drops and beta-blocker glaucoma drops, the conversation is with your prescribing physician. Neither should be discontinued abruptly without medical guidance. The questions to ask are whether the dose and duration are still appropriate, whether alternatives with a better side effect profile exist for your specific situation, and whether your eye pressure and overall ocular surface health are being monitored in the context of the medications you are taking. There is one more thing I want to leave you with, and it connects directly to what I see in patients who maintain strong functional vision well into their 70s and 80s. They have a relationship with their eye care. They have an eye doctor they see regularly. They report changes in symptoms. They ask questions about the things they are putting in their eyes. They do not tolerate symptoms silently with a drugstore bottle. And when something changes in how their vision feels, they treat that change as information. After 60, the biology of the eye is changing in ways that make it more susceptible to the kinds of insults I have described today. The tear film is thinner. The limbal stem cells are less active. The conjunctival goblet cells are fewer. The optic nerve has less reserve. These are not reasons for alarm. They are reasons for precision. They are reasons to be specific about what goes into your eyes, how often, and why. The 5 categories I have covered today: vasoconstrictor redness relief drops used chronically, preserved artificial tears used frequently and long-term, timolol eye drops in older patients without adequate systemic monitoring, steroid eye drops used without regular intraocular pressure measurement, and chronic combination antihistamine vasoconstrictor drops are not uniformly dangerous for every person in every situation. Context always matters, but the evidence is consistent enough and the population affected large enough that these deserve careful, specific attention from anyone over 60 who is using them regularly. In the next video, I am going to go through the nutrients and specific foods that the research associates with the strongest protection of the structures we have discussed today: the retina, the macula, the optic nerve, and the corneal stem cells. Because what happens inside the eye before you ever open a bottle of drops is ultimately what determines how much margin you have to work with. I will see you in that one.